Alright, so now that y'all have had a chance to take a break, we're going to pick up with nitroglycerin. Alright, so nitroglycerin is a very potent vasodilator that works very quickly to improve coronary blood flow. It does that by causing dilation of the peripheral arteries and veins. So it is not a selective vasodilator. It doesn't go directly to only the coronary arteries. It dilates everything, thus causing a decrease in blood pressure. So that's why we don't want to give this to patients with systolic blood pressure less than 90, or if their blood pressure is less than 30 than their baseline systolic pressure. So what that means is if they had an initial blood pressure of 152 systolic, you give them one nitro, you go to reassess. Now it's down to about 120. You would not want to administer another nitro because of the risk of it dropping another 30, and now you're below 90 systolic. Also, do not administer nitroglycerin to any patient who has recently taken a drug for erectile dysfunction. The reason being is, if you didn't know, ED medications was found by mistake when they were trying to find out what nitroglycerin could do. That was completely a mistake. So ED drugs does have the same effect as nitroglycerin. So within 24 to 48 hours, you do not want to administer. Also, patients may complain of a headache after taking nitroglycerin. This is a normal side effect. Also, if their heart rate is less than 50 or greater than 100, you should not administer nitroglycerin because of the potential for causing the pulse to drop, but also because there may be something else going on and the patient may potentially be bleeding out. We can only administer 3 doses. It should be given at 5-minute intervals if pain is not relieved. Typically, when a pediatric patient experiences a cardiac disturbance, it's from uh, some form of congenital heart condition that the family usually knows about. Um, Pediatric patients may also experience cardiac arrest, but its frequency is much lower than that of an adult, and the underlying cause is usually due to some type of respiratory condition rather than a cardiovascular condition that you would see in the adult patient. With geriatric patients, there may be some differences in presentation or management of these patients if an acute coronary event occurs, or if they go into cardiac arrest, based on the patient's medical history and current medical conditions. These are going to be the ones that are the highest number of patients that we experience due to their medical history, such as diabetes, comorbid conditions such as COPD, congestive heart failure, hypertension, high cholesterol. All of this stuff is, and as well, the body is beginning to fail, so that could potentially increase their chances of having an ACS issue. Table 17-2 goes over some special considerations that we want to take in patients that are in geriatrics, such as diabetes. If the patient has had diabetes for a long time, it could cause potential damage to the nerve endings within the body. Thus, they're not able to feel pain very well, if at all. So if they're having a heart attack or a myocardial infarction, they may only be complaining of respiratory distress or dizziness with no pain because of the diabetes. They may have some form of history of trauma. If they've been involved in some type of trauma, definitely if it's including the chest, you want to have a high index of suspicion for cardiac involvement as well. If they are traumatized, they can progress very quickly into a cardiac arrest and usually do not respond well to typical interventions. Asthma can also play into it. because if they have gone into cardiac arrest, the cause may be due to bronchoconstriction that led to acidosis, hypoxemia, and eventually into cardiac arrest. Until bronchoconstriction can be reversed, the patient will not regain a pulse or breathing. So we want to make sure that we intercept with ALS soon, so that way they can administer medications to help reverse this condition. And then COPD, if they have some type of exacerbation of COPD, just like asthma, can cause them to go into cardiac arrest as well. So you want to make sure that ALS backup is available and on scene during the resuscitation of this patient. Dispatch information can provide you with the first indications that a patient may be suffering from cardiac compromise. So when going through and assessing these patients, when you're directed to patients complaining of chest pain or just chest discomfort with difficulty breathing, suspect the possibility of cardiac problems. On arrival, perform your scene size up to ensure that the scene is secure, and then proceed rapidly with the primary assessment. During your primary assessment, you want to form your general impression of the patient. If the patient is unresponsive without a pulse and they're not breathing, you want to act immediately with CPR. For patients who are responsive, determine the status of the airway, ventilation, and circulation by going through your ABCs and provide oxygen as needed. As you're going through your secondary assessment, you want to start obtaining a history of the event and explore the chief complaint using the OPQRST mnemonic. Now, who can tell me what OPQRST stands for? You can tell me what the O is. Okay, onset. P. Good. Provocation. Q. All right, quality. R. Radiation. S. Very good. Severity. How about T? All right, time. You want to try to determine the duration of symptoms because this is critical in determining if the patient is a potential candidate for receiving fibrinolytic therapy. Now, fibrinolytic drugs carry many risks and are given only when the potential benefits outweigh the risks. So we have a checklist to help determine the patient's eligibility for fibrinolytic treatment, such as have they had any recent head or facial trauma, a recent stroke, or a history of bleeding within the cranium. Are they pregnant? Any recent trauma or surgery? History of GI or GU bleeding? Have they been taking any blood thinners or have a clotting disorder? Or do they have history of cancer or some type of disease that involves the central nervous system? Also, realize that many patients could have delayed seeking help because they may have thought that their symptoms may have been heartburn and it's been going on for 4 or 5, 6 hours before they finally decided to call 911. You also want to treat patients with angina that lasts greater than 20 minutes, worse angina that is progressively getting worse, or nocturnal angina as cardiac compromise. The reason being is even when they're having angina, there is still oxygen deprivation being occurred, so there could be heart damage being involved. If they have attempted taking nitroglycerin or you've given them nitroglycerin over a 10-minute period and there's still no relief of their pain, also if their discomfort lasts greater than 5 to 10 minutes after sitting down to rest. Be sure to look for all of your atypical presentations, such as no chest pain but nauseated, dyspnea, abdominal pain. While going during your assessment, you want to examine everything. Look at their pupils, because if their pupils are sluggish or dilated, it may suggest that the patient is hypoxic or perfusing poorly. Their oral cavity can also indicate hypoxia by showing cyanosis. You want to check their neck, looking for jugular vein distension, which would indicate congestive heart failure or cardiac tamponade, which is fluid in this beginning to form in the sac or the pericardium that surrounds the heart. Listen to the chest. Auscultate for abnormal breath sounds, especially crackles, which would indicate fluid in the alveoli due to left ventricular heart failure. You also want to look at the lower and upper extremities, looking for any peripheral edema, peripheral cyanosis. Also look at their posterior body, because you could also have presacral edema to the lower back, which would be another indicator of heart failure that may be more prominent in the patient who is sedentary or commonly in a supine or lying position. Now you can have chest discomfort in a multitude of different positions, because you can have pain that radiates to their chest or into their neck, their left arm, or even into their epigastric or mid-back areas. Okay, so just because they're only complaining of pain between the shoulder blades does not mean that there's a cardiac condition not going on. Make sure that you do a full, proper assessment of your patient. Go through your physical exam. Look at your, make sure you get a set of baseline vitals, and make sure that while you're getting your vitals that you're monitoring them, so that way you can start building a trend on whether or not the patient's condition is getting better or worse. Look for your signs and symptoms that and keep in mind that the signs and symptoms that correlate with cardiac compromise or acute coronary syndrome may vary widely, and just because they have one does not mean they're going to have all of them and they have something going on. They may have difficulty breathing. If they're having cool pale skin, they're showing signs and symptoms of shock, sudden onset of sweating. All right, all these are signs and symptoms that you will see. Also, the patient may be anxious or irritable, or they may feel like have a feeling of impending doom, like they're about to die. When treating for them, you want to try to decrease the patient's anxiety by keeping them calm and placing them in a position of comfort. The more at ease you place the patient, the more strain that they're placing on the heart, so it'll help save time. Also, administer supplemental oxygen. If they're dyspneic, hypoxemic, or have any obvious signs of heart failure, an O2 sat of less than 94, an O2 sat that is unable to be obtained, go ahead and administer oxygen via nasal cannula at 2 liters and titrate your oxygen flow to achieve an O2 sat of 94% or greater. If their sat is 94 or greater, but they have no complaint of dyspnea, no signs of poor perfusion, oxygen is not administered in the acute coronary syndrome patient. If the patient is prescribed nitroglycerin, you assist the patient on taking it. We do not pull it as a basic EMT. You do not pull it out of your jump bag. And if local protocol permits and the patient does not have a known aspirin allergy, you can administer 160 to 325 milligrams of aspirin. Have the patient chew the aspirin, because aspirin reduces the incidence of coronary arteries reoccluding and does have antiplatelet effects. So let me ask you a question. If you have a patient that takes 81 milligrams aspirin on a daily basis, that's one baby aspirin, how much more should you apply to your patient? Correct. Max, give them 3 more, so that way now they've taken the full 325. And if you have a patient that you're suspecting to have some type of cardiac issue, go ahead and call for ALS, initiate your transport, and meet up with them en route. Closely assess and reassess your patient's breathing and pulse at the scene and during transport. If the patient does become unresponsive with no breathing or no normal breathing, quickly assess the carotid pulse in the adult or child or the brachial pulse in the infant. If there is no normal breathing with no pulse, immediately perform CPR and, as appropriate, use your AED. Alright guys, that's it for this one. Always remember, treatment for cardiac related chest pain and other coronary emergencies must be delivered in a timely manner without error. Patient outcomes are always better if they do not degrade into cardiac arrest. If they should arrest, outcomes are generally poor. carrying with them a low rate of successful resuscitation. Um, Make sure that you're doing your Brady Labs for this chapter. If y'all have any questions, shoot me an email or send me a message and remind. Otherwise, or write them down and ask me next time we're in class. Otherwise, y'all have a good rest of your day, and I will see y'all later.